Good morning, everyone. So we do vitrectomies. Approximately 30% of the patients who undergo PRP need vitrectomy. So that's not the issue. So as the complexity of the PDR increases, one of the paper has retrospectively reviewed how many patients needed vitrectomy. So you can see a PDR with a vitreous hemorrhage, with a TRD or more complexity, nearly half of the patients might need vitrectomy. But as you see, vitrectomies, we have got vitrectomy we do for three indications, either vitreous hemorrhage, for TRD, or for tractional DME. The most important point is the TRD has got very poor visual outcomes. Hardly 50% of them will have some improvement in vision, and even 19% of the patient can lose vision after surgery. So there is a need to identify which eyes are prone for tractional complications at baseline, at the time when you do the PRP. That's important because it will reduce the incidence of the prognosis will be better. So after reviewing all our cases, what we found that as far as the tractional complications, which are very important to prevent, which will cause a significant vision loss. If you have a vitreous hemorrhage, there is no problem. Even if you operate after 6 months, there is no problem. The vision outcome will be good. So there is a specific kind of features in the fundus which will predict you which patients will develop a macula involving TRD or a peripapillary TRD. So it's the location of new vessels. So you have vessels which are on the disc and around the arcades, and the area of new vessels. So if you have a very small patch of new vessel NVD, that is not very significant. So if the area of new vessels is very large, then the greater risk. So these are the two most important risk factors for predicting the onset of tractional complications in diabetic retinopathy. So when you see such a patient, you have to have a plan of immediate PRP followed by early vitrectomy. So many of these patients have got excellent vision, so they might not agree to undergo vitrectomy. So those who refuse surgery, we have to have a very close follow-up, because it's a matter of time before they will have developed tractional complications. And the timing of vitrectomy is very important. The earlier you do, you will have a better visual outcome. So you can see this is a patient of a bilateral PDR. Right eye you can see has already got a tractional complication, and in the left eye you can see there is a PDR, HRC PDR. So if you look closely in the left eye, you can see that there are a lot of leash of new vessels which are very fine. You have to look in the high magnification, and around the disc and around the arcades you can see lot of new vessels. So you can see 6 months later we have operated the right eye. It is having siliconal inside the eye. It needed a localized retinectomy also. It was a complicated case. So 6:30 vision, and within 6 months of doing PRP, you can see this patient has developed the same problem in the left eye also. So when we operated, again the visual outcome was suboptimal. The best outcome was 6:36 possible in this patient. So that underlies the need that we need to do early vitrectomy in such patients. So this is another patient. He has undergone PRP. This is 3 months post laser, apparently doing okay, and this is after 14 months. 1 year later, patient has developed a central tractional complication, and his vision is reduced to just hand movements 1 meter. So when we operated this patient, our visual outcome was only 3 meters, and the other eye has got vitreous hemorrhage with a small traction, so he had a better visual outcome. So this underlies the need that you need to operate them earlier and follow up very closely. This is another case 3. You can see at baseline large leash of vessels in the central disc as well as along the arcade, bilaterally same presentation. So he underwent PRP, looked fine at the end of 3 months, looking okay. So 5 months later, you can see after PRP the tractional problems have started occurring. So in bilateral you are seeing the pre-retinal hemorrhages developing. So he agreed to undergo surgery in one eye, and you can see immediate surgery which we did, the visual outcome was good. Vision was 6:18, same as the baseline. For some reason he was not able to undergo surgery in the right eye, and you can see the vision has gone to PLPR within 9 months, and still he has not undergone surgery in that eye. This is a case 4. You can see again similar scenario, bilateral central vessels, and the left eye, because it was having poor vision, he agreed to undergo surgery. So after early surgery, the vision recovery was 6/12. In the right eye, because he had good vision in the other eye, he developed bleeding in the right eye, but still because he was seeing, he did not present early. So 6 months later, with a partial PRP, you can see this patient has developed a tractional detachment, and his vision has gone down, and he has undergone surgery, but his vision is only 3 meters. So if you would have done early vitrectomy, this patient would have got better vision. This is a case 5. Again, you can see a similar patient, bilateral central vessels beginning to contract, and one eye 624, other eye 6 hand movements. Sometimes the patient progress very fast, and you don't have time. Within couple of weeks, they can become blind. So you can see in both eyes he has undergone vitrectomy, though it was slightly late, but this kind of result you will not get in every case. It will be a rarity. So majority of the patients who have a large area of new acceleration on the disc and along the arcade, that is the central new vessels, you need to plan PRP followed by early vitrectomy. Otherwise, they will have adverse visual outcomes. This is the message I wanted to convey. Thank you.
Yeah.
No, you do PRP and do early vitrectomy. So within 2-3 months of PRP. No, in our series we have seen every patient develop TRD of the macula. Every patient. It's just a matter of time. Some patient develop at 3 months, some patient develop at 14 months, 16 months, but every patient develop TRD and lost vision. It causes traction because once the vascular part goes, then the fibrosis starts.
Dr. Sharad, I think another modality we can use, like little bit on the conservative side, giving intravitreal injection anti-VEGF along with PRP when the neovascularization front is flat.
That we have given in many of these patients. Okay. We have given even anti-VEGF for this patient.
Not only
but it doesn't. What we have seen, even the natural course, even if you don't do PRP, anti-VEGF, these patients will end up into same problem. If you do PRP, they will end up into same problem. If you do anti-VEGF also, they will end up into same problem. That is the natural history of the disease. Because the vessels are so large, complex, once the VEGF goes, the CTGF takes over and then the tractional problem takes over. So all of these patients need vitrectomy. See, we have got around 40 patients.
Very well documented, Dr. Sharad. The only one thing I would also have, my experience also been similar. Could it be possibility that the pattern laser is not working as good as the single spot laser that was?
Yeah,
pattern laser is not so effective.
There is a literature review which says that that the vitreous hemorrhage incidence is more in pattern laser and the regression of retinopathy is less or less. But I feel that we are not used the pattern laser in our patients. All patients are single spot laser.
Okay,
though we have pattern laser, we don't use it. We are not convinced. So we are using single spot laser on the pattern laser.
Okay, I think it doesn't matter whether single spot or pattern. My experience have been similar to you. Pattern laser, I was of the opinion that pattern laser is not working good and single spot is better. So
for HRC PDR, you need to use the single spot laser. Less severe forms of retinopathy, pattern laser is okay. I mean, it's not that it doesn't work. Yeah.
Thank you.
Thanks.
I have just one point. Dr. Sarath has nicely managed all the cases, but as far as the photograph shows, I have one suggestion. As if we do some what you call more savage laser, like coming just 500 micron up to disc and on the lasering on the flat NVs and macula also, there is temporarily lots of area vacant. If we come slightly closer up to 2 disc diameter, I think maybe few patients may have avoided vitrectomies maybe.
We don't know. I mean, as best possible, PRP has been done for all the patients. And we can't come too close to the membrane because again, that's the problem. You have to leave at least 1 disc diameter.
No membrane. Of course, the membrane is there. I mean, you have to mentally prepare the patient.
The problem is that the vessels will regress. The only thing is that the next thing is tractional complication will occur, whatever you do. Yeah, thanks.
Thank you, Dr. Sharad, for your wonderful presentation. Now we have our next speaker, Dr. Hegde Sharad, on talk Artificial Intelligence in Retina.
Thank you guys for this thing. After the chat GPT has come, now everything, the presentations and everything which is doing, in the future days it will happen like the patient will just tell them, type the message or something will come where artificial intelligence will try to get the what is the diagnosis and all. I don't know when the artificial intelligence is going to do surgeries and this part of it. So let me touch about you what is artificial intelligence and how it is using helpful nowadays in the retinal department. So what is mainly an AI? It is a study of the computer where it is trying to attempt and to put a model where it is thinking like a human mind. So it is a hardware or a software which has the capacity of being intelligent. So, for example, if you see this image, a normal computer can't distinguish whether there is a cat or there is a behind there is a clock or anything. If the computer is able to distinguish this is a cat, what you are seeing, this is a clock, what it is there, then it is called as artificial intelligence. So, and it has a various groups, which is subgroups which are there nowadays. Very much running around nowadays. What we use is deep learning and something called as convolutional neural networks. So this is like a can compare these convolutional neural networks with our brain, where they have in the neurons they have a lot of connections which are there, multiple connections. Like that, there will be like multiple internodes will be there, which will help us to classify it based on divide, and to come into a diagnosis. So here you can able to see this first image is a classic machine learning where only 2 or 3 neurons will be there, and it will give the output whether there is a disease, whether the diabetic retinopathy is there or not. And the second thing what you're seeing is deep learning, where one network which is there and it will be having multiple nodes and it will give a diagnosis. And in the deep learning you don't want to give any inputs. Previously you can able to see in the classic learning, previously some doctor has to sit or some person has to give feed the data saying this is the condition and all, but in the deep learning that also is not required. So like artificial intelligence nowadays is used in many applications. Like if you search anything in the Google the next day, or if you search anything in the Amazon the next day, whatever you search it will come that only. Similarly, any advertisement in Facebook, if you see any videos, the next videos what they come will be similar to the what videos you have seen. That is the intelligence which nowadays they are using there. And if driving also, Tesla and all, which they left like driverless driving, that is also one of the artificial intelligence. So how, when it come to health, how it is helping? So the main thing is required is the data, and lot of data wherever it is there, it helps a lot. So first and most important, radiology, where you get CT, MRI, X-ray and all. And as in ophthalmology, you have a lot of data where you take fundus photo, OCT, similarly cornea slit lamp imaging and all. So there are like various data sets now are there in the ophthalmology, like Kaggle, the IPAX, Mesidor, where they have a multiple like I can say 10,000s of lakh of images which are there, which are kept ready so that you can help it to diagnosis. So Retina, as I told you, it has a lot of opportunity for the AI to come, because we have fundus photos, we have OCT angio, B scan, where we have a lot of images and we can use it as a data. So there are mainly 3 types of classification what we see. First one is called as where we use this is classification, where we divide the condition whether the diabetic retinopathy, for example, whether it's there or not there. Segmentation means in the diabetic retinopathy whether there is any hemorrhage or is it a hard exudates. To divide like that, it will be helping. Prediction means, for example, today the patient has a mild NPDR. So what will happen in the next 2 years or the next 5 years, whether the patient is going to moderate NPDR or PDR based on the various factors which helps is called prediction. So just most important thing where AI is working now in Retina is artificial in diabetic retinopathy screening. So it has become a main focus here. So as all over the world, the diabetes is increasing. Similarly, the amount of doctors where to screen is less. So this helps us to screen whether the diabetic retinopathy or something we say it as referable diabetic retinopathy is there or not. So there are like various studies which has come, and already FDA has approved 2 or 3 softwares for that. One is IDXDR, which is the first FDA approved one, which helps for the diagnosis, and yes, Google also has it. So this is just a screen flow process where I am showing it. So initially what they do, a trained person or ophthalmologist will go and take a photograph, and this photograph will be uploaded, and the artificial intelligence, what it can do, it can see whether the patient is having a diabetic retinopathy which has to be referred and required, or there is no DR changes. And you can also keep in the middle, you can if there are some diabetic retinopathy changes, you can send it to a doctor where he will see further and he says yes, the patient has to be referred and he requires treatment. So this is the one more app nowadays where in the mobile only you can upload the photograph and you can say whether there is a diabetic retinopathy is there or not. So like various studies have come nowadays where it shows yes, artificial intelligence is helping a lot, like IDX, Retmarker, Google, IAT, lot of softwares are coming now. So this is the one of the study where I have done, where we have tried, I have annotated more than 40,000 images, and we have seen that using a smartphone in the mobile, if somebody uploads, how is the predictability, whether is it, how much is the sensitivity and specificity, and we have seen almost 90 to 91% of sensitivity and specificity of diagnosing DR. So also, as I told you, it also helps in the segmentation, where we can able to see what is, whether the patient has drusen, whether it's a hard exudates or a blood spot. So saying it can be different condition, it can be DR, it can be ARMD and all. And Google also has come that saying, by you seeing the retina, one can also say whether there is an heart attack or the Alzheimer's disease and or not. So there are like various articles have come. Coming to DME, yes, it is also trying to segment OCT and fundus photo, where they mix together and they see whether the DME is there or not, whether it has to be referred or not. So the various classifications have come on that. So this is the one study which is showing that the DME can helps us to differentiate the retinal conditions, whether it's ARMD or DME or anything. And one more important nowadays is coming in the retinopathy of prematurity, where IROP, which is the study which has been done, and it has shown it has a very good sensitivity and specificity. So this is just a one or two articles which is showing it has a very good sensitivity and specificity for the detection of the ROP, so that it can be referred immediately. Yes, in ARMD also, there are like nowadays there are like various studies which has come, and which is dividing whether patient has ARMD or wet or dry AMD. So I'll just finish. I'll just come to the conclusion as time is this thing. So yes, there are some benefits which are there. It has a faster screening and diagnosis. It has a more accurate detection of early signs of diabetic retinopathy. It has increased access to the screening in the underlying population, and it is most cost effective compared to the traditional screening. But there are also certain limitations, because it's not perfect. Still, it has to refine a lot, because there are some black box issues where it can say this is a different condition at all. And still the algorithms which are there has to be improved a lot, because it's everything what we put the image it is. Similarly, the image clarity also should be good. So if the patient has a lot of cataract and all, it becomes very difficult. It may give a wrong reading. And there is a risk of doctors to become addicted to this condition, and they may lose their diagnostic abilities. Thank you.
Any questions from the audience regarding this topic? Doctor, when do you really see this transforming into real life, seeing this technology in our clinics, in our day-to-day practice, and how far?
So nowadays, a lot of already it has come into a daily practice. One thing, screening it has to come. Few of the centers, they are doing the screening also using this, where in the mobile van clinic they are trying us. But if you see in the OCT angio and OCT, so that image clarity, segmentation and the image clarity, because OCT angio has a lot of artifacts, so it helps us to remove the artifacts, and it gives a very nice image. So it's already there in the regular life, but yes, it has to still, maybe it will take another 5-10 years to come into the practice properly.
Excuse me, sir. Like, do you have any experience with automated machine learning, with those platforms where you can, even like without codes, if you want to, without coding, if you have no knowledge in coding,
yeah,
there are platforms which are available. So any experience with that?
See, there are certain codings are ready-made available nowadays. You no need to make a coding, because like a GitHub and all which are there, they have a lot of codings which are there, but they give only a basics. For example, in a Kaggle, they did a competition on diabetic retinopathy, and they have almost 10,000, more than 10,000 codings which are available to see the sensitivity and specificity. You can directly use them, and nowadays we have something called as preset training data.
There is also transfer learning. So, like, can
Yeah,
you use that?
transfer learning, what you said, preset training data, you can use that, and you can apply to this condition, and you can see that. That's the advantage now what you are having with the what you said, like preset data training. Yeah.
Thank you, Doctor.
Yeah, Dr. Hegde, Dr. Sharath, I just wanted to ask you which software you are using for this artificial intelligence.
Means?
Which software or which artificial
So
intelligence?
no, actually what you are using now, non-magnetic fundus cameras which are there, for Zeiss have their own software. Visual Scout 100, they have their own software. Remedio has their own software.
Right.
I don't use, I was when I was annotating the images, that time we using that something called as There's a different web form which is there. Yeah.
No,
Codon will be
considering
done
the
in the Python or
sensitivity,
any other
considering
software.
the sensitivity and specificity of all this software, which one is found to be better?
I think they have published a paper also on that. Yeah.
Okay, thank you, Dr. Sharad. So we have our next speaker, Dr. Jacob. He will be speaking on my experience of laser and as adjunct to anti-VEGF in IPCV.
Dr. Jacob Chaco. है ना वहाँ पे है दाढ़ी वाला.
Good morning, everybody. I'd like to thank the organizers for this wonderful opportunity. It's not coming on to speak about my experience in this absolutely wonderful city of Cochin. It's not coming. Can I? No. I think there's an issue with the presentation. I think the best stories are anyway, and while we wait for it to start up, I think the best stories are always told with photos, and the best messages and the best discussions can be had when we have a patient and our experience with the images that we have collected over the years. So sometimes our best friends to learning are the images we have collected along the way. Can I have the presentation start? I'll just... Did I touch it? It's okay? All good? Yeah, okay. All good. I think we can start now. So I'll just start off. So this is a patient, a young female, 45, 50-year-old female who presented in October. I'm sorry?
Please carry on.
Yeah, October 2022. She had 624 parts. As you can see that this is a typical IPCV. There's a huge thumb-shaped. You look at the OCT pictures down there. You can see the huge thumb-shaped polypoidal lesion. You can see the subretinal fluid, the subretinal exudates, and the bleed. So in these kind of patients, we almost always give anti-VEGF. I think all of us here would give anti-VEGF. So here's the angio. You can see the polyps. I don't have ICGA, so depend on FFA here. You can see that we have a lot of polyps which are leaking. And what I did and what I want to discuss is how I'm been using laser. So after 2 injections, when the fluid had come down, you can see how the fluid had come down after. You can see that there's no subfoveal fluid. There's a polyp. I lasered the polyp and I covered it with I painted that lesion with a lot of small 50 to 100 micron spots with a power of around 30 milliseconds. So why did I? And you can see that 2 weeks post laser, she was 612 and she maintained that for a long time. This is an exception to the rule, but why am I talking about this? One is our demographics. What we have in our pigmented populations is that we have more PCV than CNVM. We are also picking up, after we understand the pachychoroid spectrum, we are picking up a lot more PCVs than before. Another issue is that we all know that PDT was withdrawn. None of us have access to PDT anymore. And that has been an issue for the past few years. And of course, financial constraints. We know that Eylea works very, very well for polyps, but can we all afford it? So so this is regarding the constraints regarding my trial. So that's why I did a short analysis of my experience. But the constraints is that I've used ranibizumab in some, Eylea in some, Peganex in some, Avastin in some. They've not followed up on a standardized regimen, and we did not have a control group, and of course follow-up issues. So couple of other quick, I'll go through a couple of other cases. Here we have 624 parts, polyp, subretinal fluid, and you can see that there's almost like a clovish leaf shape of multiple polyps. You can see on baseline FFA, you can see that there are leaking areas after anti-VEGFs. One anti-VEGF later, there's still fluid. I did a laser, you can see how I painted it right over there, over here. This is how I painted these lesions. And after this patient required one more laser because it recurred after anti-VEGF. Now on FFA, you can see my old laser marks, and you can see inferiorly there's still one active lesion. And 1 year later, this patient had a BSCVA of 6/9 parts, and the patient is on PRN now. Another patient, not such a good result. She started off with 6/18 vision. She responded very well. She became 6/9. There was resolution after laser, but she kept recurring, and I had to shift her to Peganex. She's 6/6, but she just got a Peganex just before I came now. So she's still taking it every 4 to 5 months. Another patient with a subfoveal polyp. The reason I put this is that after we gave a few anti-VEGFs, we realized that the polyp was regressing away from the fovea, and I managed to do a laser, and this patient is PRN on 6/9. But this is another patient this is the same patient. He developed a PEHCR in February 2023. So these patients can develop a more peripheral lesion as well. So quickly, these are the examples that I gave. Now, what is my data here? We had 18 patients who we used anti-VEGF and lasers. We gave an average of 2.3, so 2 to 3 injections before laser. I wait for fluid to regress from the fovea. Injections after the first laser was 3 to 4, and more than one laser was required in 4 out of 18. So you see, whenever there's a recurrence, I've been doing an angio and doing an angio guided laser. And the visual gain is 2.7 lines. So like I said, this is the power. The duration was 30 to 40 milliseconds, light power, and confluent applications. We had 6 recurrences, and the average time to recurrence was 3 months. And out of that 6, 3 were persistently on PRN, 3 had multiple recurrences, and they were mostly shifted onto Peganex. And among the recurrences, they had only a visual gain of 1.5 lines. Now, as a comparison, I'm coming to an end now. So as a comparison, there is another trial that used anti-VEGF as an adjuvant. So they first did the laser, and when the laser didn't work, they gave anti-VEGFs. And here we can see that there was stability in 50%, but there was improvement only in 1 out of 4 patients. And this was ICGA guided, non-treatment naive. All my patients were mostly treatment naive, and they required 3.66 injections after laser. So there's not much of a difference. You needed 3.04, they needed 3.66, and they also used 1 to 3 sittings with a slightly higher power. So what is my takeaway? I think it's better to always use anti-VEGF first. Get the polyp to regress. You need less laser. Resolution is hastened. So after it regresses away from the fovea, by applying laser, we don't have PDT. PDT would have been ideal, but when we don't have it, resolution is hastened with laser. In some cases, non-subfoveal cases, or cases where the foveal component has regressed, it might replace PDT, and it definitely seems to reduce recurrence. I thank you all for your attention, and I'd welcome any questions.
Yeah, nice presentation, Dr. Sharad.
Thank you.
The
Jake.
thing is, the protocol that you're using is it a clinical burn or a subthreshold protocol endpoint titration?
So basically, am I using a subthreshold laser?
Laser, yeah.
So I'm using not using a subthreshold laser, but I'm using very low duration. So I've shifted to that because I find that
Basically,
the amount
you aim
of
for a mild clinical
mild
burn.
clinical burn. You can see the burns.
Yeah,
You can see the burns. You can see that they're there, especially on angio. You can see the burns quite clearly. Even just on the laser, on the day of the laser, those photographs, you can see a light burn, but it does seem to really work in preventing recurrences.
How confident you are in picking up these polyps on fundus fluorescent angiography? Because in absence of ICGA, it is really difficult to pick up, or maybe
if not ICGA, OCT angio, maybe it could have.
Yes. Now we've just got OCT and angio in our center, and we plan to use that. But the thing about ICGA is we do have ICGA, but we don't have the spectralis, and I think without the spectralis is quite useless. I've done ICGAs on that, and I couldn't see anything on that. I think using white light, it doesn't really hold good. how confident am I? I think I've become more and more confident with the use of OCT, just OCT itself. When we see a large notch PED, not subfoveal, with a lot of fluid, we know for most of the cases, and you've got the clinical look of a PCV, younger patients, you can be reasonably confident that it is not a CNVM, age-related wet AMD, but a polyp.
But hitting at the PED itself may lead to RP rip and other problems also.
Yes,
You
it
have to
can.
be
I think
really-
can occur with laser and with anti-VEGF, and I prefer to shrink it with anti-VEGF first. And I see that very often, especially when we give an anti-VEGF, it tends to really reduce the amount of fluid and the vascularity. Because there's less fluid on top of that area, I can use lower powered laser, and therefore I think the chances of rip is not significantly higher. I've not had any rips in these cases, but you can't rule it out. I've had rips in patients who've received only anti-VEGFs as well.
So basically, you look at your fundus picture and your FFA both, then you decide about the treatment.
And I'm quite aggressive in repeating an FFA in a patient that has a recurrence after this.
Yeah, I'm sure. I think with OCT angio and targeting BVN, I think you may get more superior
Yes,
results.
yes, I'm looking forward to those results as well.
Thank you.
One
So-
thing, if you're saying that if it's a PCV, what sort of anti-VEGF are you using? Are you using aflibercept, or are you using, because when you're talking about recurrences, that is bound to happen with anything apart from aflibercept. Most of them don't work well. And as you're saying about giving lasers in those patients, because most there are good amount of patients where they may have it's not always that there should be a thumb shape PED. Like the OCTA has actually picked up what do you call
More cases.
more amount of polyps, and possibly those are the ones which are having a this thing. They
You're
become
absolutely
active.
right that OCTA and ICTA can pick up polyps which are not so obvious. As to regards to aflibercept, I'd love to use aflibercept in all my cases. Financial constraints is a big problem. The next thing is that you said that anti-VEGFs don't work, other anti-VEGFs don't work. That's what I'd like to say, that actually I find that anti-VEGFs, ranibizumab and Avastin, they do work as well. They don't work as well, but when used with laser, they seem to provide reasonable results. And if you use it aggressively, like monthly injections, I found that even Avastin causes a lot of polyps to regress.
Thank you, Dr. Sharad.
Jacob.
Jacob. Yeah, sorry.
Thank you.
Yeah, I request the next speaker, Dr. Sonal Jadhav, to talk on complex retinal detachments.
Thank you so much, the chair and the All India team, for giving me an opportunity to put up a topic which I think has always been a challenge for most retina surgeons. They don't have a pointer, I'm so sorry, but I think we'll try and manage. I'm going to put you through a series of few cases like giant retinal tear, high myopia with detachments, iris prolapse with GRT, RD with iris claws, and a separate case which is a Coates disease case. Let's start with my first case. This was a 45-year-old male who had, has it started? Yeah. This is a 45-year-old male who had come to us with a giant retinal tear with a choroidal detachment. You can see the choroidal fluid coming out of the cannula. But every time that I would put the cannula, I would probably not be able to see the cannula because it was going in the subretinal space. Tried and changed the position of the cannula. At that time, was confident probably that the cutter was going there. Put the infusion line again, started my vitrectomy, and just in a little while realized that I was seeing a big mound that was coming back, and the cannula was back in the subretinal space. So sometimes in these patients you see completely at the clock hours of the GRT you will see a complete pars plana which is totally off. So in these cases you are only then getting used to putting large longer cannulas, the 20 gauge cannulas that are there inside. Once that's done, then we go ahead with your regular vitrectomy, put in PFCL, flatten the entire GRT edge, do a good vitreous base excision at that point. PFCL becomes our third hand over here. In some cases, if the edge of the GRT is rolled up, you can use an soft tip to flatten that edge very, very well. And once that's done and you're confident that the edge is completely flat, you go in and you do a good laser and exchange it with PFCL, or you can do a direct exchange or do a fluided exchange and then put in silicone oil. These cases have always been a challenge to manage. Most of our GRTs now do very well. Today with the advanced new cutters, we are very confident to do a good vitrectomy and a good vitreous base dissection. This was my second case. This was a high myopia patient with a bullous RD with extensive PVR and multi-layered vitreoskisis and with a posterior staphyloma. This is the norm that we see in most high myopic patients. A very careful vitrectomy has to be done in this patient. The vitreous membranes have to be very slowly peeled off because inducing PVD is very difficult, and you can definitely occur a lot of iatrogenic breaks. In such patients, PFCL, which is mainly a third hand and also helping us to assess the traction, further traction, is very difficult to put in such cases because of posterior breaks and sometimes invisible breaks which are there in the staphyloma area. So very slowly here, circumferentially in the direction away from the disc, we are kind of peeling the membrane with the help of a forceps and the help of our cutters. As I said, the new cutters which have the port which is very close to the shaft tip help us with doing good vitrectomy. In such cases, in bullous RDs, it's very difficult to do a vitreous based dissection. So I'm going to take a small, show a small trick that is used later in this surgery. Slow and steady vitrectomy is done in these patients. You can already see a small break which is there at the inferior arcade, which is posterior. The entire membranes are very slowly peeled off with the help of your forceps today and with your cutters, as much as you can manage peeling these membranes till you are confident enough that you can now do a fluid exchange and flatten that retina. So once the membranes are completely off and you know that you can see your posterior break, you can also do a draining retinotomy in such patients. And then once you are confident that these membranes are totally off and you have cleared most of your vitreous at the posterior area with the help of your cutter and your forceps, the next step is to go in and nicely do a draining retinotomy, do a fluid exchange and flatten the retina. This is the next step that is going to be shown in the video. The light, the endolight also, the shaft of the endolight can also help us sometimes when we are doing these vitrectomies, because they can support the retina as a third hand. So that also helps us in. So you see these membranes, it was multi-layered, the entire vitreous, and as a result it was extremely difficult to peel these membranes. As much as possible was done. Finally, a fluid exchange was done with the help of a retinotomy and the posterior break, and the retina flattens. We also do a small draining retinotomy in the staphylomatous area to remove the fluid that is below the staphylomatous area. Once this is done, I think now in an air-filled eye, as you're more confident and you can have very good visualization, it's the time when you touch the further vitreous-based dissection, because the retina now doesn't jump up in your port. You maintain a good air pressure at 40 to 50 millimeter mercury. You complete the entire vitreous-based dissection, and in an air-filled eye, it becomes very easy because you can see almost right up to the aura. You don't need to indent in such cases, and you can do a good vitreous-based dissection, and then you're very confident that your surgery, in any complex RD, a good vitrectomy is the answer to doing a successful surgery. So once this is done, and then we can go to endolaser, laser all the breaks and put in our oil. Eventually this patient did very well. I'm just going to finish this video. This is the laser. You can almost see the aura right here. You don't need to indent at all in an air-filled eye. You finish the laser and put in oil. And I go back to my third case. Now, this was an interesting case that was sent to us with traumatic spontaneous expulsion of the IOL with iris prolapse with a detachment and choroidals behind. And in this case, a phakic.
Our time is up. We can have a brief discussion on this case.
Okay, so
I just see that in this previous case, the drainage retinotomy is probably not necessary when there was only peripheral breaks, and the drainage retinotomy was done in the staphylomatous area where there's no RP and all.
That's
It would
true,
have been
sir, but then
difficult
there
to
was
do
a big
endolaser
posterior
around.
bowl of fluid. So sometimes right close to the arcade, I prefer to do a small, if in case I cannot take that fluid out, because I was not having the advantage of using PFCL here, because there were small breaks at the posterior margin. So I probably did a small draining retinotomy in that case. So I think I'm just going to go ahead, and probably I know I have long videos here. But this was an exudative case, sir. But just a take-home message in complex detachments, a 240 band encerclage in severe PVR cases or inferior RDs or recurrent RDs, tricot definitely helps us to assess PVD. New age cutters are very useful. PFCL as a third hand and to assess the remaining traction. Chandeliers were bimanual surgery. A light pipe as your third hand. A brilliant view dye below the PFCL to stain the membranes and peel them better. Anterior flaps of large breaks better cut away. In large retinectomies, focal attachment points should be kept in non-traction areas, and a draining posterior retinotomy in cases of staphylo. I'm sorry with that. Thank you so
Thank you,
much.
Dr. Sonal.
Thank you.
We have the next speaker, Dr. Natasha Radhakrishnan, speaking on exudative retinal detachment.
Just a minute, Natasha.
Between the two of us, I think it's the long and the short of this session. So, good morning to you all. And as part of the LOC, welcome to AIOC Kochi. I hope you've been having a good time so far. So, my topic is exudative retinal detachments. And as you know, a myriad number of causes can cause exudative detachment. So, in the 7 minutes allotted to me, I'm planning to just tell you a few of the major causes and how you can differentiate one from the other, and what you should keep in mind when you see a patient with exudative detachment. And I don't think, like my previous speaker, I also need my pictures. Yeah, it's here. Shall I click? Yeah, so as you all know, exudative detachment is when there is no evidence of traction and there is no evidence of a break, and when it is because of the break of the outer blood retinal barrier, fluid seeps in the sensory neural space. And we can have inflammatory etiologies, of which the most common entity that we meet is VKH, tuberculosis. Yes, it's here. Yeah, so we have inflammatory etiologies, VKH, posterior scleritis, tuberculosis in our country, infectious etiology, it will come up in the chart, vascular etiology like Coats disease, sometimes in venous occlusions, vasoproliferative tumors, a lot of tumors like the metastasis, lymphomas, melanomas, and then you have a miscellaneous group where you have the uveal effusion syndrome and the B dump and other exudative detachments. What is important is your symptoms. A detailed systemic history is very important, and the symptoms are usually floaters if there is vitritis. Otherwise, they may have no symptoms at all except the defective vision. The physical findings will depend on the cause, and the fundus from the differentiation in the RD, you know, it will have a convex configuration, and unlike the rhegmatogenous RD, it will be smooth and not corrugated, and the detached retina is very mobile. Imaging and a lot of investigations will help us case wise, so we will go into the causes. So VKH is a bilateral granulomatous uveitis with exudative RD. It can also have pleocytosis in the CSF, and then later on followed by the skin changes of the vitiligo and poliosis. FA and B scan are the ones that help us more than the classic exudative detachment with shifting fluid. Here we have multiple sensory neural detachments with disc edema and choroidal thickening on B scan, and the classic fluorescent angiographic picture is pinpoint leaks with disc leak. And the management, of course, is aggressive use of corticosteroids in the beginning, but most of these patients will require long-term immunosuppression and slow tapering of the immunosuppression over about 12 months to 18 months. Biological sometimes may need to be used if there is multiple recurrences. Posterior scleritis comes in the differential diagnosis. Here, mostly the patient will have pain, and though the fluorescein angiogram remains almost the same, sometimes you may not see any leak at all on the fluorescein angiogram, but then you will find the classic T sign in the B scan. Management, again, you have to find out whether it is infectious or inflammatory, and then depending on that cause, you will need to treat. The other important differential diagnosis of VKH is central serous chorioretinopathy, not the classic one, but the multifocal one, especially the one in which you have the, when it is secondary to steroid use, when you have multiple areas of sensory neural detachment. And the main point of differentiation of multifocal CSCR from VKH is the fluorescein angiogram. Here you will have discrete leaking points, and sometimes you will have large areas of the chorioretinal atrophy, which is the area that is leaking, and so otherwise you will have discrete leaking points and then ends up in pooling. And there will be no choroidal thickening as much as in VKH. There will be no evidence of uveitis. It is very important for us to differentiate the two, because the treatment for a multifocal CSCR would be stopping steroid, and for VKH would be giving high dose of steroid. So this differentiation is very important, and one important the point is that there will be no disc leak in CSCR. How will you treat multifocal CSCR? You can stop the steroids, and you can give focal laser to those leaks if they are away from the fovea, and sometimes drugs like eplerenone can help. Accelerated hypertension is another cause for exudative detachment, and it is basically due to hypertension-induced choroidopathy. And this is a patient who had hypertension-induced choroidopathy, and then the exudative detachments can be seen very clearly. Here also you will get bilateral disc edema, no evidence of uveitis. Pregnancy-induced hypertension produces a very similar picture with exudative detachments, and you can see the FA showing delayed choroidal filling. You can actually see the areas of choroidal non-perfusion. ICG will help, of course, but you cannot do it during that time. The other differential is a uveal effusion syndrome. So now we'll move away from the inflammatory and its differentials to more less common syndromes. Here you have in this unilateral or bilateral choroidal, ciliary and retinal detachment, and it is supposed to be due to a thick sclera, and the treatment is to do a sclerotomy and allow the fluid to drain, and they have a waxing and waning of the SRF. But the classic picture is this thing that you should look for, the leopard spot appearance. So this multiple leopard spot appearance along with an exudative RD, especially on a fluorescent autofluorescence picture, that should ring a bell that it is uveal effusion syndrome. For this you need vortex vein decompression with scleral resection. Metastasis and melanomas. Melanomas less common in our part of the world. Mets are very common. Can also cause exudative detachment, and it is important for us to differentiate it from a primary tumor and for looking for the primary elsewhere. You can see the choroidal undulations and an inferior large elevated lesion here. Choroidal melanomas can also be involved, cause an exudative detachment. Here you can see the melanoma with the exudative detachment. Of course, melanoma has a very classic ultrasound appearance which helps us differentiate Mets from melanomas. And MRI can also help us differentiate melanoma from a Met. I will not go into the details of management. Let me go into this interesting case. 32-year-old lady. She was on investigation for interstitial lung disease. She has been on MMF and systemic steroids because she was a suspected Sjogren's. She presented to us with a 6/6 vision and sensory neural detachments away from the fovea. Left eye also had a similar picture, and AF showed these detachments and some RP changes. Since she was on systemic steroids, we thought that, and the fluorescent did not show a CSR leak, but it did not show a disc leak either. So we didn't think inflammatory. We thought probably steroid-induced CSR with diffuse leak that we are not picking up. ICG showed some areas of hypofluorescence. So we asked them to stop and taper the steroid and stop. 1 month later, the fluid has increased, the choroidal thickening has increased, and the RP changes have also increased. So this time we thought maybe it is related to her Sjogren's and sarcoid. She's having an inflammatory exudative detachment. We asked them to step up the immunosuppression, and MMF was increased. IVMP was given because her vision was dropping drastically. 1 month later, she has 636 and 6/6. Again, the changes are, in spite of the high immunosuppression, the changes are increasing day by day. The exudative detachment has increased, vision has dropped to 6/60, RP changes are extensive. We had no answer to give her, no treatment. We didn't understand what was going on. There is no evidence of any inflammation. And then finally, a few days later, she presented with severe backache, in which she had bilateral ovarian deposits and a bilateral breast invasive neoplasm. So this is BDUMP, bilateral diffuse uveal melanocytic proliferation, that caused her exudative detachment. So I just want to say that when you have extensive RPE changes, that leopard skin appearance and atypical features, we should keep in mind a possibility of a paraneoplastic syndrome. I think I'll not go to the next case because time is up.
First, that was very good, the BDUM case.
Yes,
Yeah,
but it
that
is
would have been-
relatively rare, so I thought I'll put
the
later.
audience should have gained more, presented the cases rather than.
True.
Excellent talk, doctor.
Thank you.
Now we request the next speaker, Santosh Gopikrishnan, to talk on chronic macular TRDs.
संतोष वन बोल के यस यस मैं कर रहा हूँ this one which one Morning. I would like to thank AIOS for this opportunity. So I'll be talking about my personal experience with chronic macular TRDs and the surgical challenges. So these are a few of the cases which I would be presenting. You know, it's quite personalized and a steep learning curve. So this is my take on it. So a desired TRD outcome would be, we would like to have this when you see a patient from CF to 6/9, but it doesn't go always like that. We do get these cases which are chronic tractional retinal detachments. What do you call the literature shows that more than 6 months of duration. These are thin and atrophic retina, extensive, thick and plaque-like fibrovascular membranes. The issue is the literature is very less, and there are no guidelines, and it all depends on individual experience and skill set. So proper case selection is critical, and to kind of get a optimized surgical outcomes. So I'll show you some cases wherein it's a bilateral case of TRD. It's a 36-year-old gentleman, DM nephropathy. This was a chronic TRD, except this point I didn't see anything else really difficult. This was a focal traction which had kind of caused a contracture there. And left eye already had a TRD, but the vision was ambulatory 636. So since it's an young patient, I thought I'll operate the right eye first. So surgery was good. There was no issues, except he had very bad hypertension because of the renal issues, 240, 140, 150. So I had to wind up the surgery. There was a severe bleed that couldn't be controlled. So that kind of went and became the membrane, pre-retinal membrane. And again, there was a tractional retinal detachment. The problem was the eye was lost. The patient was lost for follow-up for a month, and there was severe secondary ocular hypertension. So I couldn't touch the eye once again. But where in the left eye, I could have a good outcome after the vitrectomy. So this is another case of DM nephropathy. Again, bilateral TRD. I operated in 2017. It was a difficult dissection, and I had to do an RR superiorly to settle this retinal detachment. Whereas the hyaloid again here was very tough, so I didn't go in for an RR. So what had happened is, after that, the vision was good for quite some time. For 2 years, the vision was 624. Post S4, there was a thick PCO that had formed. Since there was nothing happening or nothing prior NVA and NVA before, so I went and did a AIOC caps, and immediately 5 days later he came in with a neovascular glaucoma. So we even published this. NVG is, we know that it's very common in diabetic patients, but post vitrectomy we should keep in mind about the ischemic retina. So this is a case of tractional retinal detachment. So we can there was a nasal prolif that was very taut, and it was a little inseparable. So I tried separating that. There was a hyaloid attachment there. So I had to end up doing an RR since there was a break there. So the RR part really didn't come in the editing issue. So this is how it is. This was pre-op. It's again an young patient at police, so I had to do an RR to this end, and he's doing fine. So maybe a conservative approach in this case and an encephalogram would have helped maybe. When we have a break in a peripheral dissection, then sometimes RR becomes imminent to avoid re-RDs. Then again, chronic extramacular TRDs, this we see day in, day out, as Dr. Sharath was also talking. So when you have such a situation there, when there's just a posterior pole is lifted, the arcade is lifted, and the macula is still on with good vision, we contemplate on what to do, what not to do. So these people end up having subretinal bands. So this is post-surgery, ultimately had to operate, and he settled well. Then again, there's a different dilemma whether to operate, not to operate. Good vision, government official, 618. Strangely, though, there was intraretinal split and there was a traction inferiorly. So finally, he ended up with a CRD. So I had to operate. He's doing okay, but the problem is I had issues with the peripheral dissection because of the schisis, because of the thickly adherent hyaloid there. So he's due for SVR. So hopefully, should improve further. So this is a case maybe we could have done an early surgery, but when you know that that's a better eye, and sometimes when the patient is not very keen, so we don't know really what to do. So this is another case wherein SR bands very, very close to the macula. So you can see the tautness of the posterior pole. Since it is closer to the macula, we need to be a little more careful. So I've done a retinotomy and removed the SR band there. But what had happened is there were SR bands even superiorly. So again, I had to make another retinotomy, and this time there were diffuse SR bands. So I had to kind of literally take it out with cutter, and then there was an SR band that was running right across temporal to the macula, which I had to again pick it up. This is a typical chronic case of a chronic TRD, and by manual dissection sometimes we need to start with the word go, wherein you have to use multiple combinations of scissors and cutter, and you can see the dissection there. So hemostasis again is important, and SR bands sometimes we need to kind of make multiple retinotomies to take it out to kind of flatten the retina. Once it gets mobile, you know that there are chances of the retina settling. So I kind of looked into the literature, what the tractional retinal detachment says. So there was a meta-analysis in 2023. So they had done analysis of 406 studies. So the point which was rotating around was the preoperative BCVA. So all the studies, most of them kind of focused on preoperative BCVA. So when they had a higher preoperative BCVA, the outcomes are better, and early intervention was suggested, and the other focus was to identify patients at high risk. So this was an only article I found on chronic retinal detachments, chronic macular TRDs. So then again, this also focuses on the preoperative vision. Yes. So, and older age and ischemic macula. So anti-VEGF role in better dissection, not vision directly, but macular perfusion status. So to conclude, the many factors, if you look at it, the duration, the existing ambulatory vision, and the OCT biomarkers, they do help. But the best part is, the most important part is the patient understanding and motivations. We do understand that the patient has a poor memory, and they do come back with complaints. So multiple additional opinions can be taken so that the patient is satisfied. Surgery, I feel personally, better shouldn't be hastened up. If the patient, you have to give it some time. Patient has to earn the surgery. It's a steep learning curve, and we should understand that anatomical success is not everything. Thank you so much.
Thank you, Santosh, for an excellent presentation. Now our next speaker, Dr. Aditya.
Dr. Aditya will be talking on AIOCT for retinal surgeries, why and when.
So thank you organizers for having me here. I'll be discussing about our experience of using intraoperative OCT. I've been using this tool for last about 3 to 4 years. Although I agree with all of you that it's not something which is a must, but I think it's obviously very interesting for me. So let me share my experiences with this tool with you all. So as you know, 1990s was the time when actually the OCT got introduced. It was in MIT Boston that they worked on this technology and then finally came to our clinical practice in the OPD. It has been a very invaluable tool in our OPD to diagnose various macular conditions and also to follow up these patients who are taking anti-VEGF therapy for a long time. So the journey of OCT into the operating room also is very interesting. It used to be a handheld device previously. You can imagine how difficult it must have been for the doctors to maintain a sterile field and use these kind of technologies while the surgery is actually in a very intricate phase. And just to find out what exactly the macular pathology is, to probably invest in time and probably compromise sterility is obviously not that worth it. So now with the newer version of microscopes which integrate the optical pathway of the OCT into the microscope itself, makes it quite interesting. So now with the technology that we have, the heads-up retinal surgery, the OCT also is seen by the side of the actual surgical field of view, and that definitely probably is going to be the next paradigm shift in the way we operate the retina cases. So I call this fondly as the third eye of the retinal surgeries, just like we have a PFCL, which is the third hand of the retinal surgeons. So this is a patient I am doing a inverted macular flap, and after the fluid exchange also you can see the quality of the OCT is quite good and it picks up the displaced ILM flap. So immediately I can take a corrective action and reposition this flap onto the macular hole, and which probably helps me achieve a better outcome in this particular case. This is another patient. I have removed silicone oil and I see an unusual reflex on the inferior part of the retina as if the retina is detached. So a quick retina scan can tell me that this is more like a retinal atrophy and the area is actually attached and not detached. So it saves me a lot of hassles further on. Now this is a patient who's got a retinal detachment and you can see a tiny macular hole which could have been easily missed, and under PFCL I changed the management strategy, and apart from dealing with the retinal detachment, I also peel the internal limiting membrane to ensure that the macular hole is taken care of. Now this is a patient who's probably got a pseudo hole, so I want a quick feedback while I'm operating, and I see that I confirm that this is actually a pseudo hole, and then I just take the cutter close to that area and remove that vitreous membrane to ultimately have a good outcome. So a quick feedback at the time when you are operating is always welcome. This is a patient who has a submacular hemorrhage, and we are going to deal with this with a subretinal injection of the RTPA. The value of the intraoperative OCT here is to identify the area where you have an RPE detachment and go slightly away from that area so that you don't end up injecting into the sub-RPE space. If it's an elevated sub-RPE space, you might end up injecting there, which is of not much benefit. So to inject in an area which is away from the sub-RPE detachment, and to confirm that the RTPA injection is actually in the subretinal space, the intraoperative OCT is quite helpful. Now I know many of us are called by the anterior segment surgeons to be with them when they are dealing with a posterior polar cataract. This might look very simple, that you can obviously see there is no posterior capsular tear pre-operatively, and the same is confirmed on the intraoperative OCT. But at the same time, something which is more interesting here is almost a mature cataract, traumatic cataract, and you can have a look at the bulge in the posterior capsule which is picked up on intraoperative OCT, confirming that this patient has a pre-existing capsular tear and more care has to be taken while operating on this patient. Yes, there are limitations apart from the cost. The light scattering, shadowing effect due to the surgical instruments, it hinders the view of the tissue. At the same time, the image acquisition of the peripheral retinal pathologies takes a little time for you to get used to it. So just like the PFCL is considered as the third hand of retinal surgeons, I find it appropriate to call this intraoperative OCT as the third eye for the retinal surgeons. Thank you.
Nice talk, Dr. Aditya. Can you tell me where do you exactly think this becomes indispensable? I mean, you can't do without that kind of case. Can you tell us?
I think in cases where you have a vitreous hemorrhage, for example, and after clearing up the vitreous hemorrhage, you know that you want to see what macular pathology is. Pre-operatively, it is not possible to see these patients. So it might change the treatment plan. After clearing up the vitreous hemorrhage, patient has a subtle ERM, you pick it up on OCT, you might want to peel the ERM and ILM, because you otherwise don't peel ILM in on each and every case of diabetic vitrectomy. Similarly, a patient who has probably got a cystoid macular edema, after clearing up vitreous hemorrhage, you pick it up on OCT, you might want to inject some anti-VEGF or a steroid. So at this point of time, in these particular cases, you might want to use the OCT, but I don't think we are still in a stage where it would become indispensable. I think not really, because you already have, you have an pre-operative OCT. When there is a TRD, you can always find the dissection planes using a wide field pre-operative OCT. Yes, you can confirm it while you are doing. Agreed. So yes, so these are some special situations when you feel like you may, if you have it, it's good, but it's still not a must. Thanks.
Yeah, I'll be talking about multimodal imaging in AMD. So this is a conventional way of
Dr.
looking
Santosh,
at retinal pathology.
due to lack of time, can you wind up in 5 minutes?
Fast, yeah.
5 minutes, yeah?
Yeah,
Instead
I'll
of
do
7
that.
minutes.
So conventional way, and these are the gamut of images what we have, and there have been quite some type of classifications. So if you look at multicolor and the images, how they look like FAF, and even the advanced dry AMD, you can look at atrophy that progresses over a period of time. So there are studies which have kind of compared these multifocal images and the FAF that happens over a period of time. MMI in cuticular and in pseudodrusen. There's something called fluorescence lifetime ophthalmoscopy, wherein you can see whether the FAF, signal that comes from retina and RP is old or new. Old is depicted in blue, and whereas new is depicted in red. So this is what it is, and the OCT biomarkers we all know. A CAM multimodal approach has been done in 2017 by a group of leading retina specialists. So the grading system was used to classify each modality of these investigations, whether it's recommended, optional, not recommended, and discretion. So if you look at this, OCT is always recommended, whereas the other ones like ICG and Octa are optional. So they had even classified these as Cora and Iora. I mean, most of us know all these definitions. So the band of hyperfluorescence and RP atrophy, which is complete and incomplete, that's what discriminates them. So again, these images are the ones which are used as exercise and to atrophy prediction, what happens over a period of time, and where really the atrophy sets in. And even HRD's location also was seen. You can see this refractile drusen's and hyperreflective crystalline spots when you compare it with an OCT by B scan. So these are the criteria you can compare with OCT, FIF, and in near infrared and color multicolor images. And even based on choroidal thickness, you can predict whether the patient can develop type 1, type 2, or type 3 CNVMs. Choroidal biomarkers, again, thinning, you can see in retinal pseudodrusen's, and you can kind of chart these drusen's over a period of time, how they grow over the period of time. There's a new one article which shows retro mode imaging on Mirante. You can kind of decenter it, and you can get a image from left side, and you can get it from the right side of the image, and you can see what's happening at the surface of the retina, just like an UNFAS image. So neurovascular AMDs, neurovascular image, you can know where the SHEM is, type 1, type 2, type 3. And IPCV multimodal images, you can correlate with these FA, ICG to OCT images, and you can kind of try to get to know where the PCV can probably lie and where you can do the laser, as Dr. Jacob was also talking about this. And again, you can compare this with ICG and Octa. And polyps on FA, how they look like, they do have a confluent autofluorescence with a hyperfluorescent center. And pre and post PDT, how they kind of change, the hyper changes to hypo. And Octa in AMD monitoring, you can see pre and post PDT and how the neovascular changes. And the color images on Octa also, they are really helpful when you can't really make out with a regular Octa. And Octa again really helps in different the lesion presence at different levels of CNVM, whether superficial, you can kind of get the cursor down and see where the CNVM is more prominent and what really happens there. And even unfast visualization also, you can most of the times you can see where the probable areas of polyps are on unfast Octa image as well as unfast image. And even you can look at the polyps, and this is a learning curve you can see, and you can kind of try to get a consensus of what really happens there. The choroidal vascular index again is important. And now AI, as Dr. Sharath was also talking about, the hyperreflective foci and SR deposits, and choroidal hyperreflective foci is another one which is even explored. So to conclude, multimodal imaging in AMD is an ideal way of looking at AMD. We kind of get complementary and confirmatory information. It adds to better understanding of what really happens and really helps in follow-up and prognosis. Thank you.
Thank you, Dr. Santosh.
Thank you.
Request the next speaker, Dr. Saban Haro, to speak on RVO treatment protocol. Request Dr. Saban to kindly speak in 5 minutes this talk, because I think we're running short of time.
So I'll try and make it short. Good morning, everyone, and thank you, Kochi and AIOS, for having me here. I'll be speaking on the topic of treatment protocols in retinal vein occlusion. I have no financial disclosures to make, and these are the outlines which I'll be talking on. And as we know that it is the second most common retinal vascular disorder after diabetic retinopathy, and one of the common causes for loss of vision. Macular edema, neovascularization, and ischemia causes changes in the retina. And the leading causes is hypertension in patients more than 65 years of age, and younger age group, they say systemic coagulopathy is the main cause. What's the burden of disease? Population-based studies have reported a prevalence of 0.5 to 2% for BRVO and 0.1 to 0.2% for CRVO. The risk factors that I have already mentioned, and as we know. So what are the evidence, or what are the clinical trials tell us about the different treatment protocols? BVOS study also in the pre-anti-VEGF era showed us that macular grade laser had definitely improved by 2 lines in 63% of the treated eyes, whereas in the third year follow-up visit there was 1.33 line of gain of visions. It also looked at the role of scatter laser, and it reduced the risk of NV from 31% to 19%, and it recommended that you should do a sectoral laser only after the development of neovascularization. CVR study, however, did not show similar benefit effects, so hence we are using anti-VEGF therapy or the second-line steroids for macular edema. What is relevant today is the role of PRP to address the neovascular complications. PRP was beneficial after the development of anterior segment neovascularization. So coming to the anti-VEGF era, the first line of treatment worldwide as of now, it has shown remarkable reductions of macular edema, improved visual acuity, and also decreased the neovascular complications. Ranibizumab and aflibercept are the 2 most commonly used agents. Off-label use of bevacizumab is also popular. So what are the trials? Bravo and Cruz showed that 0.3 mg and 0.5 mg versus sham in 6 months reduced the central macular thickness and also improved the visual acuity by 16.6, 18.3 and 7.3 lines. Copernicus study showed that aflibercept and sham also had versus sham, that there was a 15-letter gain in visual acuity at 12 months of time. Galileo also showed there was a gain in about 60% of the cases, whereas SCORE 2 studied the aflibercept versus bevacizumab, which showed improvement of 18.9 and 18.6 letters.
Dr. Saban, could you please summarize?
Yeah. So if you go to the different studies and the real world studies, if you go to it, long-term follow-up, they said 50% of the cases will require ranibizumab treatment after 4 years of onset of the disease. And real world scenarios by Raja Narayanan et al. Published in BMC Ophthalmology in 21 said that they also had suboptimal visual gain and they had undertreated the patients. Another study published in IGO recently showed that vision improved in BRVO cases, but it was not good for CRVO. So take home message is there is a level 1 evidence supporting the use of anti-VEGF agents. Ranibizumab and aflibercept are FDA approval, but bevacizumab is equally good enough label. Prompt therapy is indicated because delays may limit visual gains. Treatment should include PRN and treat and extend regimen. Approximately 50% patients will require anti-VEGF therapies after 5 years. Real world outcomes may not always replicate clinical trials, and so individualized approach should be tried, like steroid driven approach, a combination of anti-VEGF and steroid, or even macular laser. Thank you for your attention.
Thank you, Dr. Horo, for your wonderful presentation. We have our next speaker, Dr. Gajendra Chawla. So, sir will be speaking on OCT biomarkers. Sir, I think be brief about your talk and with salient points which we can discuss.
Sir, I would request you to be little brief and tell us more about the clinical aspects of it in 5 to 7 minutes.
I think if we are having a lack of time, we can.
No, sir, please. Sir, please.
प्रॉब्लम नहीं सर, वैसे ही कुछ नहीं बोलना सर, ड्रिल विल बोलना, कुछ बोलना नहीं है। चल भाई मेरा टॉक तो दे दो। Thank you, sir. Diabetic macular is one of the major cause of visual blindness in the diabetic patients, and intravitreal anti-VEGF is considered the gold standard treatment. While the intravitreal steroid has been established as the second line treatment, but in the literature, 40 to 45 patients do not respond adequately to the anti-VEGF injection in spite of the strict 4-weekly treatment regime, and real world scenario is even worse. The insufficient response to anti-VEGF therapy has been linked to the low normal VEGF level, and these patients may be benefited with the early switching of the intravitreal steroids. OCT has a number of morphological biomarkers are visible on the OCT, which can help us, and one can predict the treatment response and plan the treatment. The intraretinal cysts are the most common biomarker one can see, and it represents the intraretinal fluid collection, which initially they are in the small cyst, but in the chronic stage, in the later stage, they merge vertically first and horizontally to form a large cyst with the interstitial septal, which represent the remaining macular tissue. Large cyst with scary remaining macular tissue are associated with the chronic DME, and such patient may be benefited by the intravitreal steroid treatment or early switching to the steroids. Because of the chronicity of the disease, there is an increase in the vascular leakage, which can cause the breach in the external limiting membrane, allowing fluid to the transfer into the subretinal space. And this can be, these patients again will have benefit with the steroids. Intracystic hyperreflective material are clumps present in the cystic space. They can be because of the plasma, blood, hyaline, or the fibrin material. It indicates the severity of the hyperpermeability. The central macular thickness is the main parameter to define the DME and the follow-up the DME. If it is more than 253 or 300, it is considered macular edema. It is alone is not the reliable prognostic marker, but it is if it is decreased by more than 20%, it is considered a good response to the treatment. Drill is the inability to differentiate between the ganglion cell layer, inner plexiglacial layer complex, and the outer plexiform layer. It represents the disorganization or disruption of the cells within the inner layers. It indicates the disruption of the pathway and it is associated with the poor prognosis. It is sometimes associated with the ellipsoid zone and external membrane damage. If it is more than it is disorganization is more than 50%, it is indicative of poor visual outcome, and it requires early switching to the steroid treatment. When there is a disruption in the external limiting membrane or ellipsoid zone, it is again an important parameter of the visual recovery. It can be a completely disrupted or partially disrupted. If it is more disrupted, then definitely is a poor prognosis. Hyperreflective foci, again, they are the hyperreflective foci. They are the less than 30 micron in size. They are mostly in the inner retinal layers, and these dots do not show the back shadowing as compared to the hard exudates. They are indicative of the activated microvisual cells, and if it is their concentration is higher, they are more likely the inflammatory cytokine and respond more to the steroid treatment. Sometimes we can see the hyperreflective cystoid wall in the and they are again showing the chronicity of the disease, and such patient will be having the more beneficial role with the steroids. Sometimes there is a hyperreflective crystalline deposit after the treatment, and if it deposit under the fovea, the vision will be compromised. Central choroidal thickness increases with the progression of the DME, and it increases with the VEGF level. The thickest choroid thickness might be associated with the presence of SRF, and these patients again require a steroid treatment in the early phase. Vitreomacular tractions are the important factor for the treatment outcome in the treatment of DME. Sometimes there is a thicken. If you can see the photograph, one patient where we were thinking of having the cystic spaces, we have given the injections. It has not improved, but after the vitreous surgery, that patient has improved and DME is reduced. To conclude, the OCT biomarker are playing important role in the management of DME. Assessment of morphological biomarker at the baseline and over the course of treatment can help in the planned treatment strategy. It can be also helpful to decide early switch to the steroid therapy, and we can predict visual outcome with the help of OCT biomarker. Thank you for patient hearing.
Thank you very much, sir, for finishing well in time, and thank you to all the speakers and panelists for wonderful this instruction course. Thank you, and maybe next session can be taken up.